Okay, I got it. I got it. You can relax. I got this.
No, I just want to make sure that.
Okay, so we are ready to start. Dr. Millis is going to be the moderator for this session. Rick.
Thank you, Juan, for all your efforts and for this great May 2026 Research Day. I think we're all enjoying it, and thank you all for coming, participating. And I am supposed to be the moderator, so I'm going to try to moderate. I'm not sure what that means, because anybody who knows me knows that I'm not really a moderate. But I'll try my best. For this session, we're going to have oral and poster presentations. Thank you very much. And they're going to be limited, the oral presentations will be limited to 8 minutes. Is that what I'm told? But we have a microphone set up, so
2-minute question.
Yes, so get ready for anybody who wants to ask questions and start a discussion. You will only have 2 minutes. And that's only if the person sticks to the 8 minutes. But I have a special claw to take them off at 8 minutes. No, not really. I'll be monitoring the time. So without further ado, we're going to ask to come to the podium our first presenter, who's presenting an oral presentation on comparative analysis of vaginal microbiome diversity in pregnant and non-pregnant women of the Caribbean population. Let's hear it for our first group of student oral presentations. Now, this is already up for you, right?
Testing.
So do me a favor. Introduce each one of you first, so everybody knows who you are.
I just want to remind everybody that these oral presentations are going to be competing for the first prize award, which is Dr. Bandari's award of $1,000 US, and number 2, which is the AUA Research Award, which is for $500 US dollars. So our jury are going to be our keynote speaker, and the speakers, Dr. Mario de la Rosa and Dr. Henry Falk and Dr. Jose Cordero are our unbiased, independent evaluation team coordinated by Dr. Linares.
Judges and audience, Daiki, Abigail, and myself will explore the comparative analysis of the vaginal microbiome diversity between pregnant and non-pregnant women of the Caribbean population. The basis for our study is as follows. The vaginal microbiome plays a integral role in the maternal and neonatal health. It varies significantly across race, ethnicity, and geographic location. No data has emerged from the Caribbean until now. This is the first study to ever be conducted in the Caribbean assessing the vaginal microbiome composition between pregnant and non-pregnant women. Till now, all other vaginal microbiome studies have only identified the bacteriome until now. To our knowledge, this is the first research to ever be conducted globally utilizing metagenomic analysis, assessing the virome, microbiome, and biochemical functional pathways used in the vaginal microbiome. Our review study that was recently published in the Q1 journal stated that these are the community state types that govern our research. It is also notable to mention that prior studies have shown that CST4 is known to cause preterm births and stillbirth. Our objectives are simple. 1, to compare the vaginal microbiome diversity and composition between pregnant and non-pregnant women of the Caribbean diaspora. 2, to investigate the various biochemical pathways that are utilized by both cohorts of women. And 3, to highlight any Caribbean region-specific trends that may differ globally or from prior studies. Abigail will take you through the methods.
Thank you, Amar. So this was a prospective longitudinal cohort study. Participants were gathered from the Mansour Medical Clinic, and after evaluation for both inclusion and exclusion criteria, such as recent antibiotic or probiotic use, irregular vaginal bleeding, and immune-compromised status, we were left with 8 healthy pregnant women and 11 healthy non-pregnant women. Their medical and social histories were recorded, and their consent was obtained. As this is a human study, national IRB approval was given. The samples were taken from the posterior vaginal fornix and sent to Zymogen Research Lab in California for metagenomic analysis. So a bit more on this. The metagenomic analysis, or next-generation sequencing, allows for sequencing of millions of DNA and RNA fragments from a sample. The DNA from each sample was extracted, amplified, sequenced, and then compared to a known reference library to create a metagenomic profile of each individual sample. The resulting taxonomy and data were further analyzed, and Daiki will go further into detail about the results of the study.
So I introduce the result. If you see towards the right side, that is the alpha diversity based on the Shannon index. Pregnant cohort has a higher number than the non-pregnant cohort, which indicates the pregnant cohort has a higher heterogeneity. If you pay attention to the population of the non-pregnant cohort, the lactobacillus is dominated. However, if you pay attention to the pregnant cohort, there is a significant increase in the level of the bifidobacterium. So now, if you pay attention towards the left graph, this is a heat map. We found the 2 clusters, which is lactobacillus dominant and non-lactobacillus dominant clusters. Here in the middle, this is our novel finding. Specifically in the pregnant cohort, we found a higher level of the Aerococcus christensenii. And towards the right side, which is about fungi, as a whole population, the Candida was dominant. However, in the pregnant cohort, we found specifically Saccharomyces and Nagasanomyces. From this study, no virome was detected. And here is our another novel finding, which is a functional pathway. In the non-pregnant cohort, we found a higher level of the amino acid synthesis pathway. However, if you pay attention to the pregnant cohort, which is the right side, we found a higher level of the lipid synthesis pathway. Now, Amar will talk the discussion.
Thank you, Daiki. So our Caribbean cohort showed CST1 and CST3 like lactobacillus dominant in our pregnant patients. Therefore, based upon the Shannon index that Daiki would have explained, there is greater microbial heterogeneity. Lactobacillus species itself is a gram-positive bacteria that acidifies the vagina flora to minimize any maternal or fetal complications. However, the existence of Lactobacillus, Bifidobacterium, and Aerococcus suggests that this cohort does not fully align with the classical CST profiles. This mixed community pattern may reflect Caribbean population-specific eubiotic configuration. The high richness of Aerococcus in our pregnant cohorts suggests pregnancy-associated remodeling that involve a low-abundance taxa. And finally, the observed functional shift to lipid biosynthesis may reflect microbial adaptation to pregnancy-associated changes in epithelial cell turnover, mucosal barrier function, and local immune regulation. Our limitations for this research were small sample size due to non-compliance, samples were collected from various stages of gestational age, and lack of data from another Caribbean country to use as a baseline. Our future perspectives are for large prospective cohort studies from other Caribbean islands to be conducted to assess associations between microbiome profiles, to determine if interventions targeting the vaginal microbiome can improve pregnancy outcomes, pathway metabolite-based validation, and to assess pregnancy outcomes. The authors declare that the research was conducted in the absence of any commercial or financial relationships that may be construed as a potential conflict of interest. At this time, we acknowledge AUA research funding and the Zymogen Research Lab for taking our specimens. Ladies and gentlemen, it is at this point, the three take-home points from this are: 1, that there is a very vast microbial heterogeneity present in the Caribbean, as we saw bifidobacterium, lactobacillus species, and Aerococcus. 2, pregnancy has a shift in the steroid synthesis pathway. And 3, there is a significant gap in the Caribbean that other Caribbean territories must do a comparative analysis of the vaginal microbiome diversity between pregnant and non-pregnant women of their Caribbean population. Thank you for listening to our presentation. At this point, we open the floor for any questions that you may have.
Questions? Go right ahead. I always have a question, but since there are questions already from the floor, I won't ask one. Go right ahead.
Good afternoon.
I think you have to turn it on.
Oh, yes, got it. Congratulations on accomplishing these results and the data that you collected. As you said, it's extremely small sample, which limits generalizability. Now, what do you think are the clinical implications for this small study? And also, another question is, what would you do differently if you had the opportunity to do the study again or continue?
Oh, well, thank you for that question. So to answer the second part of your question first, I will say that to do a little bit differently, I believe that we can probably go out, because the only thing that we did, we got data samples from persons of a private practice here in Antigua. So next time what we can do is to go to the local hospital to increase the sample size, therefore really solidifying our conclusive results. And can you please remind me of the first question that you asked?
The clinical implications.
Right.
One, for example, you said that one of your criteria for participants was healthy women. I mean, you made me come up with another question. How did you define healthy women? And again, the question was, what are the clinical implications for your study?
Okay, so I'm just going to go back just quickly here. So healthy women were women who were outside of the exclusion criteria. So if they consumed probiotic or prebiotic in the past 3 days, they were excluded. Those who were immunocompromised and those who had vaginal bleeding were also excluded. Therefore, we were able to get those pregnant women. To answer the other part, which is the clinical implications, we found that in the child, there were preterm birth and stillbirths that were particularly for CST4 profile. However, our study did not actually track the mother's health as yet, because this is a prospective cohort study. We would definitely derive information from them, because it is still a study that we have to ask them about in the future to see if they had any complications from that.
Thank you.
Thank you.
Oh, I got one. Testing? Yes, I'm still there. I have questions of my own, but in the interest of time, there is no time. Isn't that right, Dr. Acuna? Our next presentation is titled A Novel Hybrid Device for Monitoring EEG and Brain Oxygen Level Dependent Bold Signals During Stress, something I know something about. Welcome.
Thank you, sir.
Now, let's see what we do here. We're going to, I think, take this off. Do this one. Very good. We'll do this. Excellent. That's yours?
Yes, sir. Thank you so much.
Very good. Make sure it takes the. And introduce each other. And don't hold the microphone too close.
Okay. All right. Can we start?
Yes.
Stress affects both the brain and the body simultaneously. Yet, many existing monitoring systems capture only one aspect of this response. Good afternoon, everyone. My name is Devyani Dogra, and here with me I have Punarva and Hardesh and my two members sitting right there. And today, on behalf of my team, I will be presenting our project titled A Novel Hybrid Device for Monitoring EEG and Brain Oxygen Level Dependent Signals During Stress. During the COVID-19 pandemic, millions of people routinely used pulse oximeters for monitoring their oxygen levels. Every time we placed a pulse oximeter on our finger, near-infrared light was being used to estimate blood oxygenation. FNIRS applies the same principle to the brain, allowing us to non-invasively monitor changes in oxygenated and deoxygenated hemoglobin associated with neural activity. While FNIRS measures the brain's vascular and metabolic response to neural activation, EEG measures the electrical activity that occurs milliseconds earlier. Together, these complementary modalities provide a more complete picture of stress-related brain function. To understand why combining these modalities is valuable, we first need to understand how stress affects brain activity. Stress is not solely a neural phenomenon. It is also vascular and metabolic. During stress, activation of the sympathetic nervous system and the hypothalamic pituitary adrenal axis produces measurable changes in both electrical and hemodynamic brain activity. To understand the relationship between EEG and FNIRS a little better, imagine a thunderstorm. When lightning strikes, we see the flash immediately, but hear the thunder a few seconds later. EEG is like the lightning flash. It captures the brain's electrical activity almost instantaneously. FNIRS is like the thunder. It captures the vascular response that follows when active neurons require more oxygen and blood flow. Both signals arrive from the same neural event but occur on different time scales. This relationship is known as neurovascular coupling, where neuronal activity increases metabolic demand, resulting in hemodynamic response. One such commercial system already combines EEG and FNIRS, that is the Biopac Medal Opt Plus system. While this system provides excellent signal quality, it is expensive, lab-dependent, and difficult to scale. These limitations create barriers for broader adoption in research and future clinical applications. Our objective was to develop a more portable, scalable, and potentially cost-effective alternative capable of synchronized multimodal monitoring. Our team at AUA has developed an in-house, first-of-its-kind innovative system that wirelessly transfers real-time EEG and FNIRS data to an AI-curated intuitive 3D model for immersive spatial visualization. Furthermore, This platform integrates AI-driven analytics to provide immediate, dynamic interpretations of brain activity during patient recovery. Talking about the methodology and system components. EEG acquisition was performed using BioAmp EXG module. The FNIRS module utilized 840 and 950 nanometers infrared LEDs together with photodiodes to measure cerebral oxygenation. An ESP32 microcontroller was used for signal acquisition, synchronization, processing, and wireless Bluetooth transmission. EEG signals were amplified and filtered between 0.5 and 45 Hz. FNIRS signals were processed using the modified Beer-Lambert law to estimate oxygenated and deoxygenated hemoglobin concentrations. Talking about the device working principle, EEG electrodes detect voltage fluctuations generated by neuronal firing. These signals are amplified, filtered, and digitized before its transmission. Simultaneously, near-infrared light emitted at 840 and 950 nanometers penetrates the scalp and the cortical tissue respectively. Because oxygenated and deoxygenated hemoglobin absorbs light differently, changes in reflected light intensity can be used to estimate cerebral oxygenation. The microcontroller timestamps both EEG and FNIRS streams, ensuring synchronization. This allows us to investigate neurovascular coupling by linking electrical activity with subsequent vascular response. Our prototype successfully demonstrated synchronized multimodal acquisition, wireless transmission, and real-time signal visualization. The integrated platform enabled simultaneous monitoring of electrophysiological and hemodynamic signals within a single wearable architecture. The software snapshot gives heat map user interface through a remote Bluetooth app for the researcher, switching from a wired to a completely remote model to be used in OPDs in the future. This figure shows representative raw traces acquired simultaneously from EEG, EMG, and two FNIRS channels. EMG was included as an artifact monitoring channel. Muscle activities such as jaw clenching or facial movements can contaminate EEG recordings. Simultaneous EMG acquisition helps identify and account for these noise sources during signal processing. The distinct signal morphologies demonstrate successful independent acquisition across modalities without interference. Most importantly, all signals were acquired synchronously, confirming the functionality of the multimodal architecture. This graph compares the analytical relationships between different signal modalities recorded by a device. The red dashed line at the bottom represents the conventional significance threshold of p-value 0.05. Any value below this line is considered statistically significant. The only comparison that falls below this threshold is between FNIRS A and B. This is expected because both optical channels are measuring similar hemodynamic changes, so we should expect them to behave similarly. Most of the EEG and FNIRS comparisons remain above the significant threshold. This is expected because EEG and FNIRS are measuring different aspects of the same physiological event. Overall, the graph demonstrates that the optical channels are internally consistent, while EEG and FNIRS relationship reflects the expected physiological associated with neurovascular coupling. Before discussing the graph, it is important to understand why eye-open and eye-closed conditions were included. These are widely used paradigms because they produce predictable changes in brain activity. By comparing these states, we can evaluate whether the device performs reliably across different physiological conditions. The consistent distribution of points across the conditions suggests that the multimodal system maintains stable and reliable signal acquisition regardless of the physiological state, meaning that the device remained reliable whether participants had their eyes open or closed. In conclusion, ladies and gentlemen, this work demonstrates the feasibility of integrating electrophysiological and hemodynamic sensing into a scalable platform for future stress monitoring applications. I would like to sincerely thank our mentors, collaborators, research team members, the AUA Research Center, and the Manipal Research Board for their support and contributions for this project. Thank you for your attention. We're open to questions now.
Questions from the audience? No? Well, you know me.
Was I so confusing?
I'll ask one.
Definitely, sir.
You ready for this one?
Yes.
Okay, good. So you say you're measuring the bold signal, right?
Yes.
The blood oxygen level
Yes, that's correct.
dependent signal,
Yes.
which is a measure of what?
The oxygenation and deoxygenation of the hemoglobin.
Right, in the brain,
Yes.
in the head region.
Yes, that's correct.
And what do you expect? Because I don't think it's clear exactly what the application of this is. So the application would be to do what? To correlate?
Yes, to correlate EEG and FNIRS to see whether the neuronal activity is making any changes in the hemodynamic response.
So if somebody, for example, had epilepsy, they would have a high excitability state,
Yes, that's correct.
right?
So,
You would expect to see then?
yes, so basically, as you've mentioned the example of epilepsy, in any other chronic condition as well, to detect the neuroinflammation in that chronic state, we need the FNIRS so that it can detect the deoxygenation and oxygenation of the hemoglobin. So that's why we're trying to correlate it with EEG.
Very good, because that nobody has that knowledge right now, do they?
No, not as of now.
No.
To the best of our knowledge, no.
No, we just assume clinically when a person's having an epileptic seizure, we imagine that they're using up the oxygen, right?
Yes.
But on the other hand, we know when the oxygen level goes down, the brain activity in a person who's not having a seizure usually slows down
Yes.
because there's less energy being used.
Yes, that's
So
correct.
being able to correlate that seems to be, you can get a lot of insight about brain dynamics. Okay, you have
A question,
seconds, 30
great
seconds.
presentation, thank you. May we ask Dr. Ujalbos to give us a quick explanation of the device used in this research?
Yes. Thank you for having Dr. Bose answer this, sir.
Right, thank you. Yeah, I'll be quick. So, thanks again to the entire AUA community and Manipal Research Board. The funding really helped us a lot. So what we are trying to do here is, and that's our engineer, Mr. Likit Kumar. I blinded off his eyes as well. So the prefrontal cortex is what we are looking at. We want to extract the EEG changes happening in real time. And at the same time, the time lag that exists between the EEG and the blood oxygenation. But the tools used are very simple. The devices are very cheap to incorporate. And the best part of this device is that completely wireless. So in the OPD setup, the practitioner will have an app on the phone. And the real-time changes of the EEG, I'll give you an analogy. Stress, endometriosis stress, bifunctional action. So the stress associated, monitoring the long-term stress in endometriosis, for example, will happen in real time, and the oxygenation status will also be easily monitored. So that's the overall gist of the device. Thank you very much.
Very good. Thank you very much. Thank you all. Let's hear it. Oh, we don't have time. If you have one,
What question?
20 seconds?
Yeah. Now, a very good study. What it reminds me is that we have a similar kind of investigation, what is called MRI spectrography. Now, that's a complex and very costly investigation. See whether you can extend this study into the other causes where this can be used, similar metabolic use in this study.
Thank you for that question, sir. We're actually at the moment also incorporating PPG with as a third modality with EEG and FNIRS. That's definitely a great suggestion. Thank you so much.
Thank you. It sounds like that might end up being the poor man's NMR spectroscopy. The poor man's. In other words, that means cheaper, more cost effective. Okay. Thank you. Our next presentation is titled A Novel Dual Plane Parietal Drainage Scaffold to Augment Postoperative Wound Healing and Health Economics Endpoint. So you see, as the moderator, I don't have much to do, which is what I like. but I'm good at reading titles. I'm good at reading titles. Go right ahead. Yes, very good. Thank you for telling me. Thank you for telling me. If it was only that simple. Nothing is that simple.
Hello, let me tell you guys something. Ask any woman who's had C-section and she'll tell you about the cost and the scar and the pain about it and wishing that the bikini line looked the way it used to.
So if we can solve all those problems with one device.
I'm Harshita, Med 4.
I'm Daiki Jonochi, Med 5.
And today we are going to answer all of those prayers.
So here is a background. So high-risk OBGYN patient, low transverse abdominal incision are commonly and highly associated with fluid collection. Those fluid collection can make the erythema, edema, as well as any type of the inflammation. And we have a traditional device which try to remove those fluid. However, those devices need additional stab wound, as well as we cannot collect all fluid. So now we developed a new device, and our research question is, can our device reduce those problems, as well as how we can, after we compare, how our device is better than old device. So here is a mechanism of our device. There's a 3 characteristics. First, nylon monofilament drainage scaffold is like a capillary. Those capillary action can remove the fluid from the abdominal. And second, we use the bandage, and those bandage makes a negative pressure. Those negative pressure facilitate to remove the fluid. And third, we actually push those device onto the 2 sides. One side is a subcutaneous layer, another side is a subrectus layer. Therefore, we can completely remove the fluid. So how are we gonna assess our device? We're gonna take a 3 picture right after the surgery, 48 hours after, and 72 hours after. And we're gonna make an image analysis of that picture. And for the erythema, we make the C-lab, use a C-lab to assess it. And for the edema and the closure, we actually measure the size of edema, as well as the distance of the gap. And also, we review the record of the pain score, hospital stays, length, and antibiotic usage, and analgesic usage.
Moving on to our visual results, this slide illustrates the practical application of the device and subsequent wound healing progression. At the top right, you can see the final device placement that highlights the specifically the subcutaneous and subrectus sheath strands and how the area is secured and covered after standard dressing and wrapping. As the patient is ambulatory, that encourages the fluid withdrawal. The most compelling visual evidence here is across at the bottom, where we track the actual post-operative wound progression. As you can see, the tissue is well stabilized and the stitch line is barely visible, and the acute inflammation has also reduced. As you can see, starting with figure 1, there's a sharp drop with the inflammation score from immediate post-op 0 to 48 hours to, and it's remaining stabilized till 72 hours. Following this, our figure 2 acts as another indicator of tissue redness. This graph beautifully mirrors our previous findings. We again observe a sharp drop from 0 to 48 hours, and it's stabilized till 72 hours. If you look at this next graph beside it, you'll notice that there's decreased in mean erythema index as well, which has dropped from 0 to 48, and that remains stabilized till 72 hours. Here we can see the black line shows a dramatic reduction again, and the active inflamed area drops from an average of about 12%. Coming to the next graph, which is an important finding, this demonstrates that as healing progresses, the physical spread of the redness decreases in parallel with its color intensity.
So next slide is they show the positive correlation between CLAB and the subjective clinical erythema score, which is done by clinician. And here, this left graph shows the healing process is consistent and very stable. And this step-off score and edge irregularity score showed at the 72 hours, the irregularity or misalignment of the wound is significantly reduced. And for the edema score and the erythema score, both have the same trend. Across the study, there's a significant reduction we observed. So here is the significant result. So we compare between the traditional device and our new device based on some economical factors. If you can see the left side, this talk about how long you need to stay at the hospital right after the surgery. A patient with a traditional device, we call traditional patient, they need to spend 96 hours. However, if you see the left side, this is a patient with a new device. They needed to stay only 72 hours, which is a significant reduction. Towards the middle, they said how long you need to use an antibiotic. For the traditional patient, it is 96 hours. However, for the patient with a new device, they only need to use the antibiotic 48 hours. For the right side, this shows how much analgesic you need to use. For the traditional patient, they need to use 4.5 doses. However, for the patient with a new device, they only need to use 1.2 doses, which is a significant reduction.
To bring this data together, this study rigorously evaluates the acute 72-hour trajectory in the test cases. Using our PDD, where we did the analysis, what made these findings robust was our dual method approach. The critical takeaway here is the timeline of the recovery, which is on your screen, for example. The step off, it was a great learning experience to have.
So here, also, as we noticed, there's a health economic factor we did. There's a significant reduction of the antibiotic analgesic use, as well as the hospital stay, the length of the hospital stay. From here, we can conclude that our new device has a huge benefit for the health economical point comparing with the traditional device. So there's a limitation. So our study was not long enough to prove the mechanical durability. Also, our study could not eliminate completely the possible biofilm formation. Therefore, for other future research, we need to have a long research with more volunteers, and also we need to make some modification of the device to completely eliminate the biofilm formation. Oh, sorry. So here's an acknowledgement. So thank you for everybody. Now I'm gonna accept any question.
So, it would seem to me that this is a very difficult study to do, to eliminate bias. For example, the people who are evaluating the healing, were they blinded, and all those kinds of things. Are you aware of all those techniques for eliminating bias? And in this study, did you, or was it like a pilot study where you really couldn't do that, but you're looking for future studies where you could?
So this is the actual study, the initial study, which we can actually show the possible potential of the device. So if we publish those papers, we can demonstrate those potential to the others, and we can collaborate the other team. And as you say, we can conduct, we will able to conduct like a rigid and non-biased like cohort study in the future.
So do you think oxidative stress is somehow involved in the healing process here?
I think
usually oxidative stress, you know, wherever there's inflammation, there's oxidative stress. Would you think of maybe having a biochemical marker of oxidative stress that would help you bolster your, you know, correlate with some of your physical findings?
It is possible, but actually, like we couldn't imagine those oxidative score before. So for the future research, we will consider about that.
Think about that.
Yeah.
Thank you very much. Excellent. And so, I believe we have one more oral presentation from students before we get on to the posters. So our next presentation is titled Diagnostic Accuracy of Fetal Cardiac Magnetic Resonance Imaging in Cardiac and Thoracic Vascular Anomalies, a meta-analysis. Welcome. Oop. Thanks for reminding me. Old people have to be reminded of what to do next. Let's see here what we're going to do here. 1, 2, 3, 4. You're number 4. Yes. You?
Yeah, that's it.
Okay.
Good.
See, I didn't mess it up, did I?
No, you
Good.
Okay, good afternoon, everyone. My name is Elvis Anunwa, and I'm with
Adrian Rossoff.
And Daiki Jonochi.
And today we're going to be presenting our meta-analysis, which entails the diagnostic accuracy of the fetal cardiac MRI or magnetic resonance imaging in cardiac and thoracic vascular anomalies. So, fetal cardiac MRI actually complements the first line standard imaging, which is the fetal echocardiography, by providing additional anatomical details of the cardiac and thoracic vascular anomalies. Now, a very important thing here is that's actually never been systematically evaluated. And what I mean is the diagnostic test accuracy. So my team and I, we hypothesized to actually, first of all, determine the diagnostic test accuracy of this, as well as its potential role in prenatal decision making. Now, we carried out several steps in terms of our methods. We first started with the search strategy. We utilized 4 important databases, being clinicaltrials.gov, Embase, Cochrane, and PubMed. And we were able to get about 1,559 papers, 59 observational studies. And after the full text extraction, as well as the abstract screening, we were left with 7. So we had 7 studies that included the fetuses undergoing TMRI for structural CTVAs with postnatal or autopsy confirmation. We grouped them under 5 predefined structural subgroups, and the actual descriptions were categorized in true positive, true negative, false positive, false negative. And now, very important about the false positive cell, wherever we had a 0 in our entry, we actually done a continuity correction where we added a 1 in all 4 cells. We did not do this for the true negative so as not to skew specificity. And we also carried out a risk of bias assessment using Quadus. And to actually align and pull our data, we done a pool sensitivity and specificity with a bivariate REM. And we also done an HSROC curve with 95% confidence and prediction ellipses. Now, this is our Prisma flow, and now here's our risk of bias after using QuadS. You can see that most of our 7 papers have a very low risk of bias. The 2, namely, papers that we name here that have a higher risk, and that's Dong 2020, which show the high risk in terms of flow and timing, and Herger 2024, which showed a high risk, in the index test. I'll pass it on to Adrian.
Thank you, Elvis. Thank you. So looking at the results of our pooled sensitivity and specificity, out of 2,182 lesion level diagnostic descriptions, there were 449 CTVAs that were identified. The pooled sensitivity of these CTVAs was 0.8 with a 95% confidence interval of 0.66 to 0.89. There was also a pooled specificity, which was 0.98 and a 95 confidence interval, of 0.92 to 0.99. Now, the wide confidence interval of the sensitivity shows that there was a little bit less precision with regards to the value of the sensitivity, but there was high precision when it came to the specificity of fCMRI when diagnosing these CTVAs. And furthermore, as mentioned by Elvis, the specificity was not skewed, which contributes to the precision. So moving now to our HSROC and the prediction ellipse, which can be identified by the dashed line. There's a 95% prediction ellipse area of 0.29. This reflects moderate dispersion in the study level accuracy. And what this shows us is that in a future similar single study, there would be mild inconsistency in the data compared to the data of this study. Additionally, when we look at the confidence ellipse, you can see visually that it is very small. This contributes to the precision of our data as well. The diagnostic performance in the subgroup analysis was where this study really excelled. When it came to complex critical anomalies such as left heart hypoplasia, there was a pooled sensitivity of 0.88 with a 95% confidence interval of 0.79 to 0.93. And a specificity of 0.99 with a confidence interval of 0.97 to 1. Now, this narrow confidence interval shows that the results were reliably accurate. Furthermore, if you look at the SROC, the 95% prediction ellipse, it was clustered tightly with an area of 0.04. This means that the results shown in the respective studies of this meta-analysis showed great consistency, further contributing to the precision of the study. Now I'm going to pass it on to Daiki for the discussion.
So our discussion is that our studying support fetal cardiac MRI is a great supplemental tool for the fetal echocardiogram for the case of the parietal third trimester, which is important for the to recognize cardiac anatomy to do the parietal diagnosis. Or for example, another example is that ultrasound is unavailable. And, but our development, such as Doppler sound gating, increase the quality of the MRI. However, still fetal cardiac MRI has a technical difficulty and it is operator dependent. Therefore, we need to think fetal cardiac MRI as a supplemental tool, not a replacement of the fetal echocardiogram. So there's a strength. This is a first meta-analysis of the fetal cardiac MRI at the region level, which is important for diagnosis of the complicated disease. However, there is some limitation. This study has the heterogeneity. Also, this study has the only few false positive, which we need to do some statistical correction. As a conclusion, the fetal cardiac MRI has the acceptable performance for the diagnosis. However, they also give the really important information for the fetal echocardiogram to make a targeted evaluation for multiple complicated heart disease.
We'd also like to acknowledge the AUA faculty that we could not have done this meta-analysis without Dr. Acuna, Dr. Shinoy, and Dr. Chandana Bhargavi. Additionally, we'd like to acknowledge the faculty at the Kasturba Medical College of Mangalore. Thank you. Thank you. We're open for questions now.
Okay, since there are no questions, I'll make up one. Because, no, well, I need to put him on the hot seat a little bit. You, I remember. You've been here twice already, I think. You, I remember. You guys, I don't remember. So you had a chance to answer. Let them answer this one. By the way, my compliments to your teacher. You know who your teacher is? He's sitting right there. Because what I notice, at least I think, what I notice is you're actually using the epidemiology and biostatistics, the biostatistics that you teach in class. It seems like that ROC curve is something you teach them, right? Right? So you try. So my compliments to your teacher, because this is the first presentation that I see where they go into quite a bit of detail. Now, my question for you is, I'm a little fuzzy on the ROC curve. Why is the receiver-operator characteristic curve the best way to approach this particular problem that you're trying to address based on your hypothesis that what? What was your hypothesis?
So basically, we're trying to test its accuracy. It's a diagnostic test, right? So as we've learned with Dr. Acuna, thank you again for your question, actually. As we learned with Dr. Acuna with diagnostics, very important parameters, sensitivity and specificity. Now, with the actual ROC curve, it utilizes both the sensitivity and specificity, especially when we actually do up the calculations for the AUC, which is the true positive rate over the false positive rate, being the sensitivity over the 1 minus specificity. So it answers its question. Being a diagnostic test, ROC is the best tool to use because it includes both the sensitivity as well as the specificity. Thank you.
Excellent. It's now clear to me. Very good. Thank you very much. Nicely done. Well, we're coming to the end of this session. We're going to have a poster presentation now. And even though it shows on your program that we're going to have 3 poster presentations, we are only going to have 1. Then we're going to take about a 5, 6, or 7 minute break to load up some more PowerPoint presentations. And we will, so you can go toilet yourselves, have a drink, and then come back after this next presentation. Okay? So, our poster presentation, since there's only 1, and they're only supposed to be 4 minutes, right? Is titled Diagnostic Accuracy. We just had a diagnostic accuracy oral presentation. Now we have a diagnostic accuracy poster presentation of artificial intelligence. Everybody likes to hear about artificial intelligence these days. So it sounds like it's a great topic in melanoma detection compared to dermatologists. Come right ahead. And now I will load this up for you. Hold on. I think I've got it right here. this one? Is this it? This yours? Oh, no, it's poster. Got it. Yes, I got it. That's it. Now I'm going to put this on full screen. How do we fit? Where's full screen? Perfect. Okay. Got it?
Yes. Hello and good afternoon, everyone. My poster is titled as Diagnostic Accuracy of Artificial Intelligence in Melanoma Detection Compared with Dermatologists. Sorry about that.
Did I mess that up? Would surprise nobody. So you see, it wasn't me. Because he can't fix it either. Oh, he can.
Yeah. You can just zoom in if you wanted.
No, I think that's good.
Good?
Yeah, thank you. Yes, so that is my topic. Again, hello and good afternoon. Melanoma is clinically one of the most important skin cancer because its diagnostic availability is so less, and it is very important to diagnose it early because early diagnosis can be really life-saving, and late diagnosis kind of sorry about that. Delayed diagnosis can significantly worsen outcomes. Since dermatology relies heavily on visual pattern recognition, artificial intelligence, especially deep learning and convolutional neural networks, has become a promising tool for image-based melanoma detection, which is why artificial intelligence can actually help a lot in melanoma detection. But the problem really is diverse skin types, because the artificial intelligence is usually, we take the test subjects, test images. Those are really not very trained with diverse skin types, such as dark skin colors. Usually the image patterns are light-skinned, and also it is very much trained for the normal melanoma presentations. Whereas whenever AI encounters a different melanoma presentation, such as in dark-skinned people, melanoma can show up on soles, on palms, or in the nails, which is very uncommon and not very coded in the dataset of AI. So that is the hard part for AI. But as I have seen in the research, a lot of systematic reviews and meta-analysis shows that AI has a higher rate of sensitivity and specificity as compared to dermatologists, as shown by Nader et al. And Salinas et al. Specificity and sensitivity of AI is rather high than dermatologists, but it can still not be stated that the AI can outperform dermatologists in the diagnostic accuracy of melanoma, because what it can be suggested as of now is dermatologists and AI can collaboratively work, and it can help in early diagnosis of melanoma, which is what we are looking for. The most, even though AI has shown significant diagnostic accuracy, we can still not state that it can individually perform well rather than dermatologists. But the most use of AI in diagnosing melanoma would be in areas where dermatologists are not readily available, such as rural areas, primary care, where dermatologists are not as accessible or available as they are in other places of the world. So it can act as a primary tool to detect melanoma, and it has a higher rate of true positive and a very high rate of false positive, which is sensitivity and specificity, which makes it a good diagnostic tool. But as of now, according to my research, we still cannot say that it can be used independently, but it can act as a very nice collaborative tool along with the dermatologist. Thank you.
Very good. Any questions? Why didn't you use the ROC curve?
I did not use ROC curves as of now because I was calculating sensitivity and specificity, and I used forest plots and AUC rather than ROC. But that's actually a very good method that I can use, especially after Elvis explained. So I can look into that and I can see if I can incorporate that rather than the AUC.
Good answer. Thank you very much. Now, I am told by our Dean of Research that I misspoke, so if you need to toilet yourself, it's on your own time. I'm not allowed to give you time. There's no toilet time built into the program, I'm sorry to say.
There is one more poster, but it's presented virtually.
Okay, there is another poster that's being presented virtually. And are you going to do that?
Right here? Oh, you're presenting. Cool.
Oh, well, that's not what I was told, but okay. Okay. See how they tried? It's not nice to confuse old people. They're trying to confuse me. That's not nice. So come. And you know what? I'm going to let you introduce your own poster, since I'm not sure which one it is. And this is it?
This is it.
Very good. Good luck.
Believe it or not. Thank you so much.
May the force be with you.
You know what? I'll need all the force. Thank you so much. Hello, everyone. Good afternoon. Thank you for your time. I'm sorry I'm taking away your toilet time, but hopefully it's worth it. My name is Gabrielle Cornwall. I am a 4th semester medical student. And today, I will be presenting on combining multiple modalities to improve outcomes in breach presentation, a randomized factorial trial protocol. This is combined, this presentation was done across the M2 to M4 levels, lots of different people who were able to help in the design and the development of this research protocol. So breach types. Breach presentation refers to the non-cephalic fetal position near term. The most common type of breach is frank breach, followed by complete breach, footling breach, and transverse lie. These are clinically significant due to increased obstetric complications and higher cesarean delivery rates. Management includes planned cesarean delivery or attempts at fetal version, external cephalic version along with adjunct modalities such as chiropractic care, acupuncture, moxibustion, which we'll be talking about a little bit later, and maternal positioning exercises. These may all be used to promote cephalic presentation. This study evaluates whether combining these modalities may improve outcomes. Thank you. External cephalic version. So it's done in the 36 to 37 week range. The success rate is about 50%. But this does come with high risks since you are manipulating the mother's stomach and trying to get the fetus towards the cephalic version. Some risks include maternal discomfort, fetal heart rate change, placental abruption, umbilical cord prolapse, decreased range of motion, stillbirth, and so many other things. It is also performed in a hospital with immediate surgical capability, just in case. The Webster technique is a chiropractic method used to improve pelvic alignment, and it involves gentle sacral adjustments and soft tissue work to reduce pelvic tension. The goal is to improve fetal positioning and facilitate cephalic version. Acupuncture. So it is a traditional Chinese medicine modality using fine needle acupoints. It may relax the pelvic muscles and increase fetal movement. It is often combined with something called moxibustion, and it is typically used at weeks 34 to 36 to promote cephalic version. Moxibustion, you're probably wondering, why am I saying this word? What is it? So it's basically a heat-based traditional Chinese medicine therapy near acupuncture points. And the herb that is used in moxibustion is called moxa, which I will talk about on the next slide, or mugwort. It promotes uterine muscle relaxation, and it may increase fetal activity. So the way that it's done, as you can see here, you would burn the herb and place it very close to the skin, but not on the skin, but enough so that you can feel it. And where you are doing it is the lateral aspect of the pinky toe on both sides for about 15 minutes. The goal of this is to promote natural movement of the fetus, and the mother will then go to their OBGYN and see if the baby has turned later down. Mugwort is dried leaves, or moxa, and that is what is used. It's the herbal component of moxibustion. Different exercises and yoga poses are also helped to change the breech position to a more cephalic position. While 30% of fetuses are breech at 30 to 32 weeks, only about 3% of them remain breech when it's time for them to be born. In conclusion, there are current interventions such as ECV, the Webster technique, acupuncture, moxibustion, exercises, and yoga. However, most studies evaluate these individually with limited evidence on combined approaches. This gap supports randomized factorial trial evaluating a multimodal strategy. So the goal is to see if we are able to use these different techniques rather than going the surgical route in order to promote better delivery when we do find that babies are breech closer to the term. These are our references. Thank you so much for your time.
Very nice. Question from the audience?
Yes. I have one.
Hello, Dr. Acuna.
How are you?
I'm good, thank you.
Who's your faculty mentor? I didn't see it there.
Yes, so
Okay.
I was...
Just remember, and this is for every student here, the AUA policy in student research is you must have a faculty accompanying you, right?
Yes, sir.
Second question, you propose a factorial trial, and you have 6 interventions. So your potential for arms is 6 times 6.
That is a high
Right?
number. Yes, sir.
Did you calculate a sample size for this trial?
Not at this time, no.
Okay, easy. For a factorial trial with 3 interventions, could be in the effect of this, it could be in the tens of thousands of patients that you need, right? So think about that.
Okay. Thank you.
Okay,
Thank you so much.
Okay, thank you. We don't have any more time for more questions, but I have a very good one. I understand. Okay, I'm going to ask you. I understand yoga, and I understand exercise, how that would work physically. Anybody have any idea or hypothesis about how acupuncture or moxibustion might be producing this effect?
Your question one more time?
Does anybody have any hypotheses of physiologically how what acupuncture might be doing to change the position? I understand exercise, I understand yoga. To me, it's hard to visualize the acupuncture or the moxibustion. Does anyone in the literature have any hypotheses about that?
Not at this time, but I do believe that they understand it to relax muscles. So the hope is to relax the uterine muscle and promote fetal movement.
Okay, that makes sense. Very good. Thank you very much for clarifying. Okay, I'm asked to repeat my admonition about toilet time. And with that admonition, I give the microphone to my esteemed colleague, Dr. Ravi Rajput.
Thank you, Dr. Mellis. Can I have my mic, please? Okay, so we are all having great sessions so far, and we are on to the next very important short session, which is in collaboration with McMasters. And this, spearheaded by Dr. Acuna, we have a McMaster collaboration where we have Dr. Mohit Bhandari, accompanied by Dr. Mark Phillips and Alex Thibain. They came into the campus, and we had 2 long-day in-person intensive workshop on how to do systematic analysis, systematic review, and meta-analysis. So we did that on campus, and also we had 7 to 8 weeks online sessions also, and all these students are now doing their systematic review and as well as meta-analysis, and they are in terms of preparing their manuscript for journal submission. So these 3 groups, they are going to present. And our very first presentation, so let's go with, so we have these 3 presentations. Everybody is going to do 8 minutes of their presentation, 2 minutes questions. All right, so let's begin. So our very first presentation is comparative efficacy of diacerin and NSAIDs in the treatment of knee osteoarthritis, a systematic review and meta-analysis. So for presenters, we have Rebecca, Daiki, Anake, Punarva, Joe, and the rest of the faculty members. Thank you.
Good afternoon, everybody. We will be presenting our systematic review and meta-analysis on the comparative efficacy of diacerin and nonsteroidal anti-inflammatory drugs in the treatment of knee osteoarthritis. Our research partners are mentioned on this title slide here, and our group members as well. So knee osteoarthritis is a major cause of chronic pain, reduced mobility, and a decreased quality of life. While NSAIDs are commonly used and are effective, they are often limited by significant adverse effects, especially with long-term use. Diacerin being an alternative treatment with a different mechanism of action, its effectiveness compared to NSAIDs is still unclear, and because of this uncertainty, which is why we did the meta-analysis and systematic review. Our research question was, in adults with symptomatic knee osteoarthritis, is diacerine comparable to NSAIDs in reducing pain using validated scales? We conducted a literature review following a structured process, beginning with a search strategy development in addition to our inclusion and exclusion criteria. We then searched the databases PubMed and Cochrane Library. We used the platform Covidence to remove duplicates, screen the titles and abstracts, and perform a full text review, all in which were done by 2 independent reviewers to reduce bias. Ultimately, 4 randomized controlled trials met our criteria. Our primary outcomes were pain and function using the VAS and WOMAC scores. Overall, the strength of evidence was moderate to strong due to consistent study design and low heterogeneity.
All right. So hello everybody. So for the inclusion and exclusion criteria, we decided to include studies that were just randomized controlled trials, as well as studies that were, we made sure that they only compared oral dicerine with oral NSAIDs, and made sure that all of the studies used validated pain scales like VAS and WOMAC and had extractable data, as well as the population was over the age of 18 as an adult, and they had physician-diagnosed knee osteoarthritis. For our exclusion criteria, we made sure to make sure that we excluded studies that would maybe limit comparability, as well as possibly limit comparability. And these would possibly include pediatric populations, perhaps some non-randomized studies, as well as any sort of review or observational studies that might have been conducted, as well as studies that may have used wrong comparator groups that don't follow our inclusion criteria, for example, ones that have combination therapies, and perhaps don't have validated pain scale measures in their outcomes. And as we were going through our research, we discovered that now NSAIDs comes in different types. So there's selective COX-2, and there's also going to be the non-selective NSAIDs. Now, as we're comparing dicerine versus NSAIDs, we wanted to also make sure that we do a subgroup analysis in order to evaluate whether these different types of NSAIDs could possibly result in different treatment effects.
So hello everyone. We use the PRISMA guidelines to ensure a systemic and unbiased selection of studies. We initially began with 110 studies, which underwent abstract and title screening. And then from there, we were left with 21 studies, which underwent full text review, ultimately leaving us with 4 studies that met our inclusion and exclusion criteria. And these were the 4 studies that were used in our meta-analysis. And now, to assess the study quality, we used the robust RCT and we use a robust RCT along the 6 domains, including randomization and blinding. And all the studies showed to have a low probability to a very low probability of bias, indicating that the information used was reliable.
So here's the result. We use a first plot, and we check the BAS score. As you can see, the standard mean difference is a little bit favor on the diacerine side. However, the confidence interval is crossing the no effect line. Therefore, we conclude that there is no statistical significant difference between the diacerine and NSAID in terms of the BAS score. If you can see the I-square, which is 0%, which indicates there is no heterogeneity between the studies. So here is a WOMAC score. As you can see, standard mean difference is 0.08. However, again, the confidence interval crossed to the no effect line. Therefore, we conclude there is no statistical significant difference between diacerine and NSAID for the WOMAC scores too. And here I squared is 0% too. So there's no heterogeneity between the studies. Now we'll talk the discussion.
Okay, so to conclude, our studies found that there were no significant difference between diacerin and NSAIDs in the treatment of symptomatic knee osteoarthritis. After pooling our data from the 4 randomized controlled trials, we found that there was a reduction and an improvement in function. But because our size of studies were so small and our confidence intervals crossed 0, we basically had no meaningful, significant difference between the groups. The major strength of our study was the consistency across the pooled data. And this is very important in meta-analysis because you want to have a holistic view of what's really happening clinically. So as Daiki reiterated, our I-squared of 0% indicates that our results were concordant, meaning that the comparison of COX-2 inhibitors and non-selective NSAIDs should be noted. Some of the limitations of our studies included the number of studies, the differences in the treatment duration, and also the long-term effects of the data. We also cannot completely rule out a type 2 error. And we cannot rule out the type 2 error because the population size is so small and it's unlikely that that small difference in variation is actually clinically meaningful. Our future studies should include possibly larger sample sizes, longer follow-up periods exceeding 6 months, structural outcome measures, and an evaluation of the combination therapies that were excluded. In our analysis, we excluded studies that were multi-armed. Overall, our findings suggest that diacerin has a minor difference, but it actually may be very useful in patients that are intolerant to NSAIDs. So finally, we'd like to thank our AUA Research Center and faculty, and we'd also like to thank our collaborators and mentors from McMaster University. Their guidance and mentorship were invaluable during this research process. Thank you for your attention. At this time, we'll open the floor for questions.
Okay, great presentation. The floor is open for questions. Oh, so we have one.
Thank you for the presentation. In the introduction, you mentioned that perhaps one important difference between the 2 interventions was safety, but that was not included as one of your outcomes. Do you remember what information is available in the trials about the safety profiles of the 2 interventions? And perhaps you can consider including that as an additional outcome. Because if the efficacy is the same, but one intervention is safer than the other, that could make a difference.
Yeah, so did you notice any adverse effects you want to highlight?
Thank you.
The 2 groups?
Oh, sorry.
Yeah, can you highlight any adverse effects you noticed, like when comparing the 2 groups, diacerin versus NSAID?
Yes, so NSAIDs typically have gastrointestinal side effects, a lot of them being stomach ulcers as well. So I think one of the guidelines for NSAIDs as well is to take it with food. And I think for NSAIDs specifically, that would be the adverse effect. Diacerin specifically also has, it wasn't specifically an arm of our trial, so that would be something that we'd include in another arm trial that we would include in the future for that. I think it's mostly cardiovascular effects, but it wasn't too noticeable in from what we were looking at as well, if that answers.
Okay, all right, so we have another question.
Yes. My question is, I assume you only included articles that were written in English. Is that correct? Only
Yes.
English? Okay.
Yes.
And that's a limitation, of course. And my other question is, did you look at variables such as gender, race, ethnicity? Did you examine
Yes.
any of those?
Yes, thank you for your question. We did, and we have a study characteristics table in our final manuscript, but with the limit of 12 slides, we had to pick and choose what we had to include, but we have tables that discuss that. Yes, we did.
Also, the WOMAC and VAS scale are very standardized scales that are used to measure pain threshold. So utilizing that was actually very significant. So in terms of our studies, we also looked at forest plots, but once we did our meta-analysis, we went from about 100 plus studies down to 4. And that was because most of the studies looked at various groups of types of drugs. So in the case of, we wanted to really hone in on diacerin, but going in the future, we'd want to go back to our primary sources and include those 3-armed or 4-armed studies. And I think we would have a more valuable meta-analysis in the future if we continue it. And thank you for your question.
All right, thank you. Thank you so much for presentation.
Dr. Ravi, one question.
Yeah, we have one question.
Just a quick question. Very, very interesting research. What's the mechanism of action that is proposed for diacerin?
Okay, so the mechanism of action of diacerin is an interleukin-1B inhibitor. So that is interleukin-1 beta is in charge of cartilage degeneration. So that's an inhibitor of that, if that makes sense.
Great. All right, thank you. Yeah, diacerin is considered as a very different, not in the class of NSAIDs, but very different mechanisms. Okay, so on to the next presentation. So as you can see that these topics which are selected, they're more specialized topic, and especially in the field of orthopedics and sports medicine. So next, we'll go with our next presentation, which is on effectiveness of Nordic hamstring exercise in preventing hamstring injuries in soccer players, a systematic review and meta-analysis. So we have presenters Elvis, Francisca, Imoni, Zenia. Welcome.
Hello, hello. All right. Good afternoon. My name is Francesca Prieto, and I'm here with
Elvis Inonua.
And today we're going to be presenting our systematic review and meta-analysis on the effectiveness of Nordic hamstring exercise in preventing hamstring injuries in soccer players. All right, so hamstring injuries are the most common muscle injury in professional soccer, as seen in both male and female players. These injuries are also associated with a substantial amount of time lost from the sport and with high reoccurrence rates, which creates a significant financial and physical burden for both the athletes and the teams. Early randomized controlled trials, RCTs, investigated eccentric hamstring strengthening programs, but there was one in particular, this Nordic hamstring exercise, NHE, reported promising reductions in hamstring injury incidence. So this led us to formulate our PICO question of, among soccer players, does a Nordic hamstring exercise reduce the incidence of hamstring injuries with the secondary outcome of a reduction in the severity of injuries? So now I'm going to be discussing our methodology. So as you can see here, we have our Prisma flow diagram, and we identified studies with the use of PubMed and the Cochrane database. All records were imported into Covidence, where duplicate studies were removed. And from there, we were able to do title and abstract screening with 278 studies, and they were assessed for eligibility. Full text review was then completed and performed. Ultimately, we were able to come up with 10 randomized controlled trials that we decided to further work on. Okay, so now I'm gonna be discussing the risk of bias with those 10 papers we're working with. So as you can see here on our table, for the selection, reporting, and for attrition, it's generally considered to be low. Whereas with performance bias and with detection bias, you can see that it's generally high. But that's to be expected, because with performance bias, it's hard to blind. the athletes. They already know what exercise regimen that they're going to be completing. And for detection bias, it's also difficult to blind for the outcome assessments. And from this, we generated 2 forest plots, one for the primary outcome and one for the secondary outcome. And we also generated a funnel plot for the primary outcome. Now, this was all done with the help of metaanalysis.com. So I'm going to be discussing the forest plot that we see here. I want to point out the 44% of reduction in the hamstring injury for those who used the NHE versus those who didn't, as seen also with a relative risk of 0.56. Now, I'd also like to acknowledge the I-squared score of 53.8%, which is moderate to high heterogeneity. My team and I, we hypothesized that this possibly had to do with the Enger-Breston 2008 paper, which showed data moving against the NHE. So we decided to do a sensitivity analysis on this.
And that's exactly what we've done. So we've done a sensitivity analysis, which entailed excluding a paper to see if it actually improved or decreased the performance of our papers. So when we took out the Enger-Breston paper, we see a 47% decrease in reduction, which is obviously increased in comparison to the previous slide, and we also see a decrease in the marker of heterogeneity at 30.5%. So this prompted us to go into another critical reappraisal of the Enger-Breston paper, where we see that there was actually a poor compliance by the participants for the actual exercise. After that, we also plotted out the funnel plot, and as you see here with the funnel plots, we can acknowledge the asymmetricity of the actual papers. We've done 10 papers, and you can see it's slightly asymmetric, and this is a possible publication bias. But as she said prior as well, we also carried out the secondary outcome, and the secondary outcome entailed days absent. Now, most of our papers didn't actually particularly talk about the severity of the injuries, so only 3 of these papers went into depth about this. So we decided to exclude the 7 and work with the major 3 that were very consistent with that unit of days absent. And as you can see in the forest plot, there is no significant difference with the actual days absent and those who utilized the NHE in comparison to those who didn't, as well as we can see a 0% for the heterogeneity. And this prompted us to kind of hypothesize that the actual NHE was more utilized for pre-injury. So it was a protective effect where it would increase the eccentric strength as well as increase the fascicle length of the hamstrings rather than the actual direct healing process. Now we can go on to the strengths and limitations of our paper. As looked at with previous systematic reviews, we show a significant reduction in the hamstring injuries, and our sensitivity analysis actually provided more strength and importance to our paper and highlighted the importance of the actual compliance as a theme for heterogeneity. Now, our paper also considered, with the actual papers, they considered different training volumes. So certain papers used high repetitions, high sets, while others used low sets and low repetitions. And this enhanced clinical relevance. We were also able to see that the high sets and high reps tend to perform slightly better. Now, that in itself can also be a limitation because there is limited evidence on what's optimal for these participants to take part in, and that's something that needs to be noted in future. Another thing that needs to be noted was the inconsistent injury definitions. So certain papers were inconsistent with that, as well as reporting of recurrence of injury. And there were variations in NHE protocol where certain papers would go through solely NHE, while others would do the NHE in a protocol called the FIFA 11 Plus protocol, and that somewhat dampened the actual isolated effect of NHE in reducing the hamstring injuries. Yes, and that's another thing that needs to be noted was there was a slightly low general external validity, as most of the participants were males or within the age of 18 to 36. There was only one paper that included females. So this is something that needs to be noted in future, where we need more RCTs, including female football players. Now we can conclude our meta-analysis demonstrated the effectiveness of NHE in reducing the incidence of hamstring injuries. There was also a large amount of heterogeneity seen across different themes, and also concluded that there was no significant difference in the implementation of the protocol on days absent. Now we want to acknowledge our AUA faculty, Dr. Kwanakunia, Dr. Rajput, and Linares, and the McMaster faculty for this amazing collaboration. Thank you so much.
Okay, completed within the time. So any questions? Floor is open for questions. Yeah, just for the last, the days absent. So what do you think the data, do you want to comment on based of the number of studies?
Yes. So for the days absent, even though we only use few papers, with 3 papers in comparison to 10 for the primary outcome, we actually see that there are a lot of participants. You see with the experimental, the 300, control, the 700, so they're close to 1,000. Obviously, more research needs to be done, more papers need to include this to further be confident about its lack of effect on the severity. But from what we've seen, this is pretty strong. Thank you.
All right, thank you. Thank you so much. So with interest of time, let's go to our last presentation of this session.
Sorry, I was standing here.
All right, oh, sorry. Okay, please go ahead.
I just wanted to ask for the presenters, did you guys look at what other hamstring strengthening exercises were in the existing training protocols to directly compare the NHE to?
Yes. That's something that will be done in future papers. Like I mentioned before, there was the FIFA 11 Plus protocol that included different types of exercises. I'm talking flexor exercises, upper body exercises, and within the hamstring exercises, not only did they do the Nordic curls, they also done the hamstring curls, which is using the machine itself to basically flex your knee. So that's something we can do in future, but as of now, we didn't carry out that comparison. But thank you.
Thank you.
All right, thank you. So we are moving to the last presentation of this session, which is on platelet-rich plasma formulation for acute hamstring injuries, effects on return to sports, and re-injury recurrence. Systematic review and meta-analysis will be presented by Adnan, Shamir, Gehad, Mohammad. So welcome to the presenters. All right, so it's over to you.
Hello everyone, my name is Jihad Saleh, this is Adnan Omar, this is Shamir Kanwar, and this is Mohammed Al-Tahan. And our study focuses on comparing different platelet-rich plasma formulations to standard physical therapy in athletes with acute hamstring injuries to evaluate their impact on time to return to sport and risk of re-injury. So why hamstring injuries? In a study by the UEFA League Club Injury Study in 2023, hamstring injury rates have doubled from 12% to 24% over 21 seasons. Another study shows that there's a link between higher injury rates and lower league rank placements, which leads to reduced competitive success. And a final study shows that injury-related underperformance costed teams £45 million per season. And so why PRP? PRP has a great biological potential. It delivers a 3 to 5-fold increase of key growth factors in addition to cytokines and other essential repair factors. The global PRP market is estimated to increase by over $1 billion within the next decade, and there's literature inconsistency due to unresolved knowledge gap. And so what is PRP? Or how does it work? The PRP process works by first drawing blood from the patient, then centrifuging the blood and separating it by the 3 layers. And it's the buffy coat layer that's what's extracted, and that's what's injected into the patient using ultrasound.
For our systematic review, we focused on the athlete population suffering from acute hamstring injuries diagnosed with MRI who received PRP combined with physical therapy versus physical therapy alone, looking at two outcomes. Our first outcome, how many days did it take for the athlete to return back to their sport? And secondly, what was the likelihood of re-injury, or the re-injury rate? And limiting only to RCTs. We did a systematic review using two databases, PubMed and Cochrane, where we yielded 153 studies. After our inclusion and exclusion criteria, we were left with 5 articles. And you can see in our meta-analysis, our 5 articles span from 2014 to 2025, with the right side being our forest plot of our first outcome. And the horizontal line indicates the confidence interval within each study. And the longer the interval, the horizontal line indicates how imprecise it is. And once that line crosses the line of no effect, which is the horizontal line, it means that it's statistically insignificant. And we can see out of the 5 studies, 3 of them are statistically insignificant. On the bottom left, we see our pooled data of all 5 studies. We are at 229 participants combined, with a mean difference of 6.5 days sooner for athletes who receive PRP compared to the control, with the upper limit of approximately 9 days sooner, with the lower limit of 3 days. And our I-square, which means heterogeneity, is at 36%, meaning which is moderately dissimilar studies in our pooled data, likely due to biases and structural design of each study, where there's double-blinded in one study and some studies did not have that. Therefore, the results would be different. And our p-score of 0.0001 indicates that it is far from chance. For our second outcome, we see that we only have 3 studies left now that reported re-injury rates and a risk ratio of 0.77, meaning that athletes who received PRP had 23% less re-injury rates compared to the control, with a heterogeneity of 0%, indicating for these 3 studies and this outcome, due to the results, they were more similar and were better comparing apples to apples, with a p-score of 0.41, indicating that is statistically insignificant. But we do need to keep in mind that there is possibly a clinical significance due to the reduction risk, or the risk in injury, and due to the fact that all 3 studies favor PRP and are on the left side of this forest plot, and is likely due to the smaller sample size and a type 2 error, and we will discuss how we can get the power up to 80% and what sample we should recommend for future trials.
Okay, so here you can see that we have 2 funnel plots. One's for our primary outcome and the other's for our secondary outcome. Looking at these, you can see that the citations we use don't center around the line of no effect. So this means that there likely is a publication bias, but because of how few sources we actually have, we can't say for sure that there is or isn't one. Here you can see we have our risk of bias domain. And so we did it based off of 5 different domains. It was randomization process, bias due to deviation from intended intervention, bias due to missing outcome data, bias due to measurement, and selection bias. And looking at our sources, you can see Hamid 2014 towards the top and Lai 2016 towards the bottom. We judged to have the highest risk for bias. In our discussion, we've noted that athletes who get PRP can return back to play within 7 days sooner, but that effect is likely bias driven. We want that in the future in further studies that there's double blinding done for all studies. Also, we saw that re-injury rate did go down amongst players who did get PRP, but we also noticed a likely type 2 error. To get a higher power of 80%, we think we need about 1,600 participants, so 800 in the control receiving only standard rehab protocol, and then 800 receiving the standard rehab protocol plus PRP. Finally, one limitation that we saw is that there's a lack of standardization amongst all the studies. So in the control alone, there's a lack of how often patients will receive standard rehab, and comparing studies, we found that on average, those who received more standard rehab without PRP returned back to play 17 days earlier than those who received rehab only once a week. And also there's a lack of standardization in the PRP protocol and the formulation.
Thank you, Shamir. So for our conclusion, our first conclusion, we concluded that PRP does modestly accelerate the return to sport for athletes. However, given the biases with a low certainty of evidence, it should not be a routine practice, and it should only be considered for selective patients with a clear understanding of the uncertain benefits. Our second conclusion was PRP shows a clinical plausible reduction in re-injury and a risk reduction of 0.77 and a number needed to treat of 17. But this remains imprecise when underpowered without statistical backing and confirmation. For future clinical trials, what we recommend is there needs to be a clinically meaningful outcomes with long-term re-injury that looks at long-term re-injury with imaging and pain and strength scales. Also, rigorous trial designs that are double-blinded, standardized, and controlled. Re-injury power trials need to have a minimum of or approximate of sample size of 800 per arm. Thank you, guys. Any questions?
Thank you so much. All right, so floor is open for any questions. No questions?
On me.
Oh, we have one question. Yeah.
Okay. Number one is, did you look at bias in those articles? And because you mentioned bias so much also, what suggestions would you take, or what precautions, in addition to double-blinded, right? I mean, that's obvious. But what precautions do you take to prevent bias in similar studies?
Yeah, we used the Cochrane risk of bias analysis tool, which was in that slide with the 5 domains. Can we go back?
Mm-hmm.
Yeah, so pretty much in these 5 outcomes, if we can design a new study that was at low risk, it provides enough substantial evidence for future evidence. Because right now, we're limited in the amount of studies, and they're highly biased. So one would be double binding, second would be selection biases, performance biases being eliminated just by more of the design. So specifically, the design I would recommend is the double blinding. Any other recommendation? Oh, we said the randomized control trials, which all of ours were, and just those are the main contributions, and ensuring that data is not missing. Because we did have some studies with missing data. That's
about biomarkers. Would you think about biomarkers?
Biomarkers? That is very interesting. We will make a note and look into that. And one final thing was just deciding on a standardized return to sport. because everyone has a slight different definition on how long it takes for an athlete to return back to their sport. So being standardized across all studies would be great. Yeah, thank you.
All right. With the interest of time, we'll take
Thank
the
you.
last question. Thank you. Yeah.
Thank you so much. Good research, guys. My question here is, did you guys try to check into the cost effectiveness of using the plasma alongside with physical therapy?
Yeah, so roughly an injection costs roughly around 1,000 to 1,500 USD, and insurance does not cover this, so it is likely due to not having scientific backing. So cost effectiveness, we did not do a cost analysis, but just making a hypothesis, if athletes are interested or companies, it would be in their best interest. But for a regular patient, it might not be in their best interest, cost-wise.
Yeah, so that's where I was going, because looking at the cost of doing such a procedure and the number of days that you have to return back to service or to sports, I think it's something that you need to look into, because that will motivate them to get into the procedure more.
No, definitely. But for a top elite athlete, one day can mean a tournament, winning a whole competition. So for them, it does matter. Yeah, thank you.
Thank you.
All right, thank you. Thank you so much for all these three wonderful presentations. We are going to take over to you, Dr.
A 15-minute break. We will start promptly at 3, our faculty presentation session. Sorry, 12 minutes break.